Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8-Minute Rule. I got Mark and Drew here with me. We're going to go over a quick case of anterior knee pain. So we're looking at 28-year-old runner, anterior knee pain going on about 8 weeks, typically worse with stairs and hills, not an unusual thing to both of you guys as well. So I'm going to get our timer going here and start some things up. And what we'll do is let's start off. Drew, why don't you give me, if you could take a look at one single test to get the most information out of it, what's it going to be?
So I think one of the most important things for this patient, while it might not be day one, definitely by day two, is watching them do the activity that causes pain. There's a lot of information you can get as far as strength, because I think that most runners don't do enough strengthening, but making sure that you get eyes on the activity, I think, is a key part of that early in the plan of care. So some sort of a get them on the treadmill, gait analysis, or at least minimally watching them run.
To your knee pain with running, let's look at them run. I like it. All right, Mark?
Yeah. I mean, I think Drew's definitely spot on there. If I take that out of the equation, maybe they're not appropriate to go run day one. I'm going to look at either a single leg squat or a single leg step down. You can get a ton of information as far as mechanics there. I don't even do hip abduction manual muscle tests anymore because I look at it functionally. In a single leg squat, you're going to get probably much more reliable and repeatable data as far as hip strength than I do with like trying to make sure they're in the exact same position every time on a manual muscle test and everything.
Yeah, I think those are really good. For me, not to copy yours, Mark, I think the single leg squat means a lot. Depending on how far this runner is running, there's gonna be a lot of value to see what do they look like at the start versus you have them go run for 5 minutes, 10 minutes, whatever have you, and take a look and see what looks different out of that as well too. That can give you a lot of useful data. As you said, especially since stairs are a provocative motion, I think some kind of loaded knee flexion is going to give you a lot of information there if you're looking at something real quick. All right, so both of you guys, Drew, as you mentioned, strength is a component here. We know that likely to be true. So when you're looking at kind of patellofemoral versus quad weakness versus the hip, where do you go first?
Looking, if it's a mechanical thing, I will often, if they have pain with squatting, step downs, things like that, if you try to correct the movement, whether it be with some cueing, using bands to see if it makes any sort of a change by having either better mechanics, that can be a good, or sometimes manually if you just kind of shift the patella into a different position if they're having just that irritation behind the patella over and over again. I know when you look at some of the taping studies, oftentimes it's not a specific direction, it's more of a certain area, and maybe sometimes more compression can spread out the load of the posterior side of the patella, and that can ease the symptoms. So looking at changing the mechanics or shifting or putting a different pole onto the patella to see if mechanics can change it, or sometimes the taping can ease the symptoms if it's really irritable, just to help calm it down. I think that was the question you asked. Was that what you were asking and going for?
Yeah, that works for me. Mark, what do you think?
I think so. Most of the time, if it's like a patellofemoral pain syndrome issue, it's a motor coordination thing. So it's usually not actually a true strength deficit, although I will say strength training for runners is super important. But oftentimes you'll notice improvements in pain levels, even in the absence of strength improvements. And so it's more so coordination activation type activities for the lower extremity. And I say it like that because it's not necessarily quad, not necessarily hip. It's yes to all of the above. Now, I will say the research does target hip abductors and quad as the primary muscle groups to really target, but for each patient it might be a little bit different. I'm going to get a lot of information from the functional tests that I've already done that may tell me, oh, this person probably going to start with a little bit of quad activation, or maybe this person I'm going to start with a little bit of hip activation, or hey, maybe I'm going to do something where I'm getting a little bit of both and then retest. And I will tell you, doing a manually resisted hip abduction and side lying for like 3 rounds of 5 with like a slow eccentric, slow concentric phase that will like absolutely fry their hips out. Stand up, do another step down, and it is actually mind blowing even from a provider side of things, the difference that you'll see in some folks that need that.
Yeah, I love that stance as well too, and absolutely, it's not a plane of motion that's getting worked a lot, especially in this category individual. Yeah, I'm gonna take it a little bit of a different direction, in the sense for me, and we don't know obviously with the case information that I've shared what the background is, but typically, 28-year-old runner more than likely not somebody that's doing a whole lot of plyometric work, not somebody that's been doing that kind of training to some degree. I agree with both of you guys. We're probably treating some irritability on the anterior knee structures more than anything else, and so we're trying to figure out what's a neuromuscular deficit we're probably looking at. But one of the things that I do like looking at is just from a dynamic load. Obviously, I used to be solely focused on kind of the single limb stuff, and the different step downs from squats, and then obviously looking at manual muscle tests for hips and quads and hamstrings and everything else, kind of negating the fact that obviously when you're running, it's a dynamic movement. I mean, it's a completely different load, as you guys know, than just doing even a single leg squat. And so I think there's a lot of value too, and what I want to go towards, especially depending on the irritability, is really looking at, have you prepped your tissues for dynamic loading? Is this somebody that just started picking up running? Is this somebody that's been running for 8 years and all of a sudden now they're having knee pain? But I think really looking at, are we looking at, and it could be more of a patellar tendon issue when you're looking there, but just from the dynamic load standpoint, are they ready? Do they have the right mix in their protocol to be able to do that? And that also could be down the line. You got to get stuff calmed down first, and then you're working towards that. So,
You've,
uh, yeah, go ahead.
I'll say we've talked a lot about like the objective stuff, but you bring up the subjective portion, which I think is a really important piece of this of how have they progressed training? Do they have a plan for running? Those types of questions in subjective can be as much, if not more, valuable information to help them get over what they need to, because it could be training error, which is a lot of it.
Yeah. All right. So each of you has about 10 seconds for this question here. So, Mark Powell, do you shut down running or modify?
Hardest question in 10 seconds. I think the reality is that some of these folks are not going to, even if you suggest it. And so I think having a clear agreement around, hey, if you continue running, this is what it looks like. It may take a little bit longer, or it may not get better, or whatever, so that they can make an informed decision about their running.
Drew, anything different?
Quick one is it depends. New runners, I think the encouragement is to try to modify and keep them going so that they can continue whatever new health practices, whatever it is, why they got into running. For the runner who's been a long time runner, like Mark said, they're probably not going to shut it down. So initially, you can try to modify it, things like modifying cadence, distance, the training load. And then ultimately, if those things aren't changing, you might have to get to where you're shutting down and building them back up. But that's not my first go-to for 90% of people.
All right. Good stuff, guys. As always. Till next time.